You can start when you're ready, Nazeer.
Okay, good evening, everyone, and welcome again to the G-ECHO program. This is hosted by the Gastro Foundation in association with Project ECHO from the University of Mexico. And just to remind you all that it runs every second Monday at 6 o'clock in the evening. And today I'm proud to introduce Dr. Isneen Hilmy, who will give a talk on approach to upper GIT bleeding, particularly the non-variceal subtype. And I encourage one and all to post questions on the group, and hopefully we can have a meaningful discussion afterwards. So over to you, Isneen.
Thank you, Nazeer. I'll just share my screen. Okay, thank you for the introduction. So I'm Isneen, I'm from GSH UCT. I'll be following up on this talk on approach to variceal bleed. So today we're going to do non-variceal bleed. So, so just to define like what is an upper GI bleed, we've got this ligament of Treys, which is a thin triangular double fold of the peritoneum. And it has a superior component and an inferior component. The inferior component basically acts like a suspensory ligament, which kinds of holds the duodenum and the duodenal jejunal flexure. And the superior component is basically a skeletal muscle which arises from the right crus of the diaphragm at the level of the esophageal hiatus. And so the upper GI bleed is where you have bleeding proximal to this ligament. And when we say severe GI bleed, it's basically documented GI bleed, which means patient is having either hematemesis, melena, hematochezia, or a positive NG lavage, along with signs of volume depletion like shock or orthostatic hypertension, and decrease in hematocrit at least by 6%, or the need for at least 2 pints of blood transfusion. And just to so that we're on the same page, the overt bleeding, it means that you have the visible signs of bleeding from the GIT. And if you have occult bleeding, that means you have subacute bleeding that is not clinically visible, and the obscure bleeding are the bleeding from a site that is not apparent after your routine upper endoscopy and a colonoscopy or a push enteroscopy. So the symptoms usually, usually the patient presents like hematemesis or a coffee ground emesis or melena or hematochezia. So hematemesis basically means vomiting out of blood, which is indicative of bleeding, but it could be from the nasopharynx, esophagus, stomach, or the duodenum. And usually this is bright red, and it basically suggests that there has been a recent or ongoing bleeding. Coffee ground emesis, this could be dark like coffee material, which suggests the bleeding has stopped some time ago. And it can also be due to non-bleeding pathologies. So one should be wary that look for any obstruction, but obviously it also might be because of the blood. And then the common other symptom would be melena. So the black tarry stools, due to it happens because of degradation of the blood into haematin and hemochromes by the intestinal bacteria. And basically melena can signify that it originated from upper GI bleed. Sometimes even the colonic bleeds, you can have melena with that, so we should be wary. At least 50 to 100 ml of blood is required for you to have melena. And it occurs several hours after the bleeding event. And even after the bleeding stops, it can be present up to 3 to 5 days even after the bleeding stops. Hematochezia, it's bright red blood per rectum, which suggests colonic or anorectal bleeding. Or if you have a massive active upper GI bleed or a small bowel bleed, you can still get hematochezia. And yeah, so if the bleeding is severe and there's a rapid transit, you can see blood in the stool as well. So for the approach, so once patient has bleeding, we look for different causes for bleeding. We take a proper history from the patient. So like we ask the patients if they had any nasopharyngeal radiation or nasopharyngeal malignancies or recurrent epistaxis. This could point towards a nasopharyngeal cause. Or if you have to differentiate between hematemesis and hemoptysis. And then are there like any evidence for esophageal ulceration? That could be history of GERD, heartburn, heavy alcohol use. Does the patient have difficulty or painful swallowing? Any history of pill ingestions, or has the patient had a history of having a nasogastric tube placement? And then if the patient has esophageal cancer, one would ask for symptoms of dysphagia, any history of Barrett's. Does the patient have weight loss? And if patient had been binging and then he started vomiting out blood, one would think of a medullary wastia, or repeated nausea and retching, severe retching, one would think of a medullary waste. And if the patient had history of a large hiatus hernia, we should also think of Cameron's ulcer. And more importantly, it could be like varicose bleed, so portal gastropathy. So we also ask and look for features of cirrhosis, any comorbid obesities, and angiodysplasia should be suspected in patients who have cardiac diseases like aortic stenosis or chronic kidney failure, or in patients who have systemic sclerosis as well. And if you had a history of being eradicated for H. pylori or diagnosed with H. pylori, we should also think of, and if you had like epigastric discomfort or use of any NSAIDs and grandpa's aspirin and previous history of peptic ulcer disease, we should also think of PUD as one of the cause, which is one of the very common cause which we find. And always suspect if the patient has weight loss and early satiety, is this a gastric cancer? And primary enteric fistulas and secondary enteric fistulas should be suspected as well. Sorry. And if patient had a recent ERCP or a sphincterotomy, then one would suspect this is the bleeding coming from the ampulla, or if they have had a recent liver biopsy or a cholangiography, then or TIPS, then we should think, is this coming from the bile ducts, pancreatitis, pseudopancreas history, pseudocyst history, and yeah, so we should also think of the pancreatic duct pathology. And small bowel malignancy is also something we should be wary of, especially the Lynch syndrome. So, and then any intra-abdominal metastatic cancers or history of intermittent small bowel obstruction, and recurrent unexplained GI bleeds or weight loss should be asked in history. And Meckel's diverticulum. So this is basically a true diverticulum. And remember the rule of twos, the 2% population, 2 inches in size, 2 feet away from the ileocecal valve, 2 times more common in females. And so this should be suspected if you have unexplained GI bleeds, which is less than, especially in patients who are younger than 40 years old. And small intestinal ulcerations. So we again ask for history of any drugs that would cause the ulcers, or history of IBD or relevant histories. And in Osler-Weber-Endo syndrome, we also ask for nosebleeds and small intestinal telangiectasias. They are more commonly seen in patients who are more than 60 years of age with chronic blood loss and iron deficiency anemia. So, and we also ask about history of any prior intestinal surgical anastomosis that has, because sometimes this anastomotic ulcers because of the ischemia. You can get anastomotic ulcers that bleed as well. And it's also important to ask if they had received any intra-abdominal radiation, because yeah, one would think of radiation enteritis in this patients. So once we get the history, so the history and basically the ABCs should go hand in hand, and it's very important to stabilize the patient. So we check the airway, breathing, circulation, and regarding prophylactic intubations, they have not been like studied prophylactic intubation in patients with upper GI bleeding in large randomized trials. However, there are a few meta-analysis that have shown that prophylactic antibiotic does reduce the incidence of pneumonia, length of hospital stay, and in mortality. But however, in some studies that has actually showed that it's increased. So we don't have, if you look at the Bavino 7 guidelines, which talks about the varices, so they say if the patient is bleeding, has a continuous bleeding or unconscious, then we can intubate the patient. And the European non-variceal bleeding guidelines, they actually say that prophylactic intubation should be performed in the context of severe hematemesis, or if the patient is agitated, or if you feel that the patient is, you're not able to protect the airway of the patient. And we also send blood typing and cross-match. We do a full blood count, full chemistry, renal functions, liver functions, and coagulation test as well. And then one would transfuse. So regarding transfusion, should we use a restrictive or liberal transfusion? So restrictive, so the restrictive transfusion means whether you have a threshold of 7 to 8 gram per deciliter. In liberal, most of the studies there we use 9 to 10 as a threshold. And if you look at the meta-analysis, which had almost 12,500 patients across 31 RCTs who required transfusion due to a range of different causes. One of that was acute blood loss compared to outcomes based on restrictive versus liberal. What they found was it really did not alter the mortality at 30 days. So the restrictive transfusion was not associated with bad outcomes, even in patients with coronary artery disease. And they were not able to make a comment on the acute coronary syndrome because of lack of data. So for stable patients, they say that without history of acute cardiovascular or acute of cardiovascular disease, then your threshold would be less than, for transfusion should be less than 7 grams, and you should target your blood hemoglobin to 7 to 9. And if you have acute or chronic cardiovascular disease, then your threshold would be 8 and your target would be 10. So now across most of the guidelines, all major guidelines, they say restrictive transfusion is preferred and standard of care, and it is recommended. And in case of severe bleeding, British society guidelines, they do not advise a target-oriented resuscitation. However, if you look at the variceal guidelines, they say that the venous stat should be more than 70%, and it should easily measurable level with the resuscitation settings and useful guidelines for clinicians. And regarding clotting factors, we have limited evidence with regards like regarding the need or even the threshold for platelet transfusion in upper GI bleed. British Society Guideline Consensus, they advise a threshold of less than 50. And this is based on major hemorrhage protocols. And in variceal bleeding, no evidence suggests that platelet actually correlates with the ability to control bleeding or rebleed. So if you look at the NICE and BSG variceal guidelines, they advise a transfusion threshold of less than 50, and the Baveno 7 the consensus, they advise the correction of platelets can considered like an individual basis. And regarding FFP, there's no clear benefit. And the US variceal surveillance guideline, they did not advocate for its use in patients with cirrhosis and even upper GI bleed. So coming back, so we have then the other thing is we have to risk assess these patients. So there are numerous risk assessment scores that can be used to prognosticate patients with upper GI bleed. Sorry. Yeah, so one of the, so these are some of the most commonly used prognostication scores. Obviously, one would use a pre-endoscopic score to determine how soon the patient needs or like a scope. So we have Rockall classification, AIMS, and the Glasgow Blatchford scores, which are the best studied out of all. And however, if there was no score particularly good at predicting rebleeding or death. So if you look at the Glasgow Blatchford score, basically they talk about symptoms of melena, and they talk about the hydration status and then the comorbidities. So if you look at the main thing they talk about is actually melena. So what about hematemesis? So they don't really touch on that. So these scores should not be taken like 100% at face value, but rather it should be a guide for us. And if you look at the GBS scores, if it is 0 or 1, these patients, they can go for a outpatient management. And if it is more than 8, then one would consider a high care or ICU admission. Yeah. So ICU also, if they have hematochezia, syncope, shock, comorbidities, onset of bleeding in hospital, these patients can be considered to manage in an ICU setting. So initially, you would not know what is the cause of GI bleeding. So is this variceal or non-variceal? So if you suspect the patient has chronic liver disease, or if the patient had confirmed chronic liver disease, we can start with a somatostatin analog. And then and also if you're not suspecting the patient has chronic liver disease, you can go for a high dose PPI therapy if you suspect peptic ulcer disease. And then one would go for endoscopy. So before we talk about the timing, just a small thing about antiplatelets. So regarding antiplatelets, if it was given for a primary prophylaxis, you can stop the antiplatelets, aspirin especially, and if it is given for secondary prophylaxis, one would consider to continue the aspirin. This is based on the RCTs which had been done on patients who had for the secondary prevention. So they found that these patients was associated with major cardiac event, 3 times more risk of getting a major cardiac event. And this risk was almost 90%, 90-fold more if the patient had stents placed. And they found that stopping significant aspirin had a significantly higher 30-day mortality rate versus patients who were actually using them. So if aspirin was temporarily stopped due to a life-threatening bleed, so time to resumption would be varies across guidelines. Some say you can resume after your endoscopic hemostasis is achieved. Others, they say up to 5 days. And Plavix or clopidogrel, So there are limited evidence on dual antiplatelets. However, if patient has stents, then the risk of occlusion is high and it must be balanced. So we always get our colleagues from the cardiology side to weigh on. And if you had severe bleeding, obviously one would continue aspirin, but would stop the clopidogrel. And one would start clopidogrel maybe within 5 days after stopping, after achieving hemostasis. Regarding anticoagulation, if there's severe bleed, that suggests that the patient on warfarin, the drug has to be withheld. And we would give vitamin K in addition to the faster acting of 4-factor thrombin complex. And FFP is generally not preferred because we need to use a lot of volume to get the benefit of it. And in severe, less severe bleeding, one would assess the risk versus benefit of continuing anticoagulation. But I think if there was if patient came with bleeding, we would generally stop the anticoagulation. And US guidelines suggest that endotherapy is appropriate for patients with an INR of less than 2.5. So we aim to correct the INR at least to below 2.5 before we would intervene. And in European guidelines, they advise reintroduction of warfarin after hemostasis is achieved within 7 days, and taking into patient factors, obviously. And regarding DOACs, the European and BSG guidelines, they suggest to temporarily withhold the drug, and yeah, that's usually sufficient given the short half-life of these drugs. And pre-endoscopic agents, so like the British guidelines, they actually recommend to give, sorry, the American guidelines, they recommend to give IV erythromycin for all the patients who you would be scoping. So basically we give 250 milligrams for 30 to 120 minutes before the scope. And basically what it does is it improves the gastric mucosal visualization. It reduces the, and also the studies have shown that it decreases the transfusion requirement and the need for second endoscopy, and also decreased length of stay. The BSG sorry, just give me one moment. So the BSG consensus bundle, they advise the use of erythromycin in selected patients, and it's they've left it at the discretion of the endoscopist. And regarding tranexamic acid, so it basically it's an anti-fibrinolytic agent. Usually it's used by OBS and sometimes by surgery due to major bleeding in trauma. However, in upper GI bleed, there's no, yeah, so the versus placebo, there's no improvement in 5-day mortality. And most of the guidelines, they have not recommended it. And regarding PPI, it might decrease the need of endoscopic treatment at index endoscopy. And it does not improve more clinically relevant endpoints like mortality, rebleeding, or need for surgery. So different international guidelines, the Asian ones, the European ones, and the US ones, they're not really consistent on the recommendation on the use of PPI. So coming back to time to endoscopy. So early means within 24 hours. So this is preferable to the later endoscopy. So if you look at the current guidelines, the evidence does not appear to support urgent endoscopy less than 6 hours. And they actually, even the variceal guidelines, they recommend 12 to 24 hours. Yeah, so appropriate resuscitation and optimization during that first 6 hours is more important. And yeah. So this is the Forrest classification. So sorry. So basically, in the first classification, we classify the patients into acute hemorrhage, whether the patient had signs of recent hemorrhage, or are there any lesions without active bleeding. So so type 1, and it also gives us a nice rebleeding risk. And so if you look at type 1A, that means you have active spurting, as you can see here. So the chance of rebleeding risk in this patient is actually 60 to 100%. So definitely one would want to do endoscopic endotherapy in these patients. And if you look at 1B, so you have active oozing. Once you wash, you get active oozing. And these patients, they again at 50% chance of rebleeding. And sometimes then you look for any signs of recent hemorrhage. So then you go to the type 2s. So here you have type A, where you find a nice visible vessel, as you can see here. And these are like non-bleeding visible vessels, so they can actually rebleed in 40 to 50%. So you need intervention. At least most of the major guidelines, they say intervention in 1A, B, and 2A. And adherent clot. So these are patients who have adherent clots, and they are at 20 to 30% risk of bleeding. And if you look at the American guidelines, they say if you wash with force and if you can dislodge and reveal what's underneath there, then you have to intervene. And some guidelines, they say, yeah, not to intervene. So it's a bit gray zone. But most of the time, what we do is we take a snare or a biopsy forceps, try to move the clot, and then do intervention in these. So, and then sometimes you'll see these flat spots. So these are very less likely to rebleed. So they basically these are 2C lesions. So they just have a 7 to 10% chance of rebleed. And you are always happy to find the Forrest 3 ulcers, which is a clean base, and they have a very the least, that is 3 to 5% chance of rebleed. And some of the other things which, when we go for emergency scope, what we find would be Delafoy lesions. So these are some tortuous submucosal vessels that has ruptured into the stomach in this absence of ulcers. So if you happen to wash them, you can clearly see where the bleeding is coming from. And then obviously a bleeding angiodysplasia, which is also a common thing, which we can see part of, but normally they don't cause massive upper GI bleeds. And then we should always be wary. Sometimes we do find these very bad esophagitis that have been bleeding. And in some cases, you would also find like polyps that are bleeding, and one would want to intervene in these patients as well. Okay. So coming to endotherapy, so we'll discuss each one by one. So we have injection. So basically what we do is we can either take an injection. Normally we use the 1 into 10,000 epinephrines, and we inject around the ulcers, usually around 1 to 2 centimeters, 2 millimeters away from the bleeding point. And what it does is it actually provides a tamponade and action, and it induces local vasospasm. Even the American guidelines, they mention that you can use absolute ethanol also, and other sclerotherapy to inject. However, the problem with injection is it is temporary, so you can't use it as a standalone treatment. You always combine it with another mode like clipping. So these are some resolution clips. We get 360. So basically what we do is we place the clip over the bleeding site and try to get, it's not always easy like this way it slipped. So you can even put at the base, bring it close and then close it out. And the other, if you fail the first endotherapy with injection and clipping, one would consider OVESCO as a second line treatment. Or if you think there's a fibrotic base and your clips won't be beneficial, in these cases you can actually go for OVESCO after injection, or OVESCO as a single therapy. And regarding hemospray, the use of TC35, basically it's used in patients who have like gastric cancer, and there's no specific bleeding points, it's bleeding everywhere. And you can use the catheter tip, place the catheter at 1 to 2 centimeters from the bleeding site, and then you apply 1 to 2 second bursts until it stops bleeding. And these are very good to achieve hemostasis in patients with gastric cancer, as I said, but generally it's used as a bridge to a definitive therapy, gastrectomy, or yeah. And then we've got bipolar electrocoagulation with gold probe, or sometimes you can use direct heater probe as well. So basically you use a large probe, 3.2 millimeters, and you use 15 watts, and you have to give firm pressure on the bleeding spot for 8 to 10 seconds before removing. If you remove it early, sometimes all you do is expose the blood vessel and it starts bleeding. And APC, something we are very used to doing. So basically it's you use argon with a flow rate of 1 to 2 liters per minute, and use a power setting of 40, generally start with 40, and a probe you keep around 2 to 10 millimeters away, and then treat those angiodysplastic lesions. And multiple studies have shown that each single endotherapy modality to be comparable in achieving hemostasis, except for the epinephrine injections, which are temporary, and it should not be used as monotherapy. So post-endoscopically, regarding PPIs, so we generally give IV PPI. You can either opt to give infusion after that, 8 milligrams per hour for the next 72 hours. This has shown to reduce risk of bleeding and need for surgery and even mortality. And when they compared between PPI IV boluses or oral PPI at high doses, potentially to lower the cost, they are actually equivalent to the continuous infusion. So for high-risk patients after the IV PPI and endoscopy, the American and other international guidelines, they actually advise the patients to be on a BD PPI for at least 2 weeks. And regarding the H. pylori eradication, so if peptic ulcer is found, then one would test for H. pylori at the index endoscopy, and you would do either RUT or histology. And if H. pylori is found, then we would generally eradicate the H. pylori. If H. pylori is negative, the European guidelines, they advise to retest with 4 weeks and eradicate for H. pylori. In our settings, sometimes it's not that easy to get a second endoscopy that quick. And we generally, if the patient has a peptic ulcer, we would put on high dose BD PPI, and upon discharge, they generally get eradication. And what do you do when you have ongoing bleeding or rebleeding, or if you are not able to stop the bleed. So that's always a stressful moment. So when would you repeat an endoscope after you thought you had achieved hemostasis? So one is if the patient has externalization of blood, and then if there's a reduction in hemoglobin less than 2, or if you have tachycardia, hypertension, so that is when we would repeat the scope. And if bleeding cannot be controlled, then we would involve the interventional radiology for transarterial embolization, or even call the surgery to bail us out. And the European guidelines suggest the use of Ovesco or hemostatic powder in these patients until you get a definitive treatment. And there are a lot of emerging therapies. So they've used machine learning models. So basically what the current scores, it just gives you the it's not a dynamic score that we have the current. So these machine learning scores, they are more dynamic, and it might provide a real-time assessment of the patient. And yeah, and then you have Doppler probes. It could be used as an agent. So before we inject, before therapy, you can actually know where the vessel is, so it could be more precise. And there are other like hemostatic techniques and powders like endoclot, next powder, and yeah, and studies are still going on for this. So these are my references. Thank you.
Okay, thank you, Isneen. I think it was an excellent presentation on an approach to non-variceal bleeding. If there are any questions, I think in the chat box, I think it would go through. Okay, VG has corrected your spelling for Julifoy and Melina.
Yes.
Okay, so a little bit on that. Maybe while we're on that, maybe just tell us a little bit about the Julifoy lesion. Those are the scary ones.
Yeah, so these are basically tortuous. It's in the submucosa. Patients, they sometimes it can actually hide when it's not bleeding. We've seen some patients who we don't really know the cause for upper GI bleed who comes in. We have scoped multiple times, and yeah, it's very easy to miss. And basically, we can either use Ovesco, or we can use multiple clips to achieve hemostasis.
Is there any questions from anybody else? The floor is quite open, so you can ask Isneen directly if you want to. Viji, from your side, any comments?
Yeah, I think there's something on the chat over there about from Dominic. Do we use the same dosage and volume of epinephrine for small intestinal lesions? Okay, so small intestinal bleeding lesions, example, duodenal cap or D2 Forrest 1B ulcer. Any risk of ischemia in the small bowel? I don't know if Isneen wants to have an answer and
Yeah.
attempt at answering that.
Yeah. So if it's in the duodenum, it's we have very limited access to it. So we can inject, and then we can even use gold probe as a second, because as I said, injection is not primary. I mean, it can't be used as a standalone treatment. So we can either use a gold probe on it, or and using Ovesco clips in a very tight area, it would be very challenging for most people. And regarding the dosage, they've only mentioned they've mentioned So you can 10,000 to 20,000 dilution, and
Yes.
10 units, 10 mils to 20 mils should be, yeah.
Yeah, no, I actually agree with you. You can use, if you're concerned about ischemia to the small bowel and you think you're injecting a bit too much, usually, look, it's really hard to go over 15 mLs. And the recommendation, I think, Isneen, you can correct me if I'm wrong. I'm sure you've read this more recently than I have. They normally recommend in upper GI bleeding to use about 15 and even up to 30 mLs of and you can really go down with your dilution of epinephrine to 1 in 20,000. Having said that, I sometimes don't even use any epinephrine at all. On the occasional case, I just use normal saline just for that temporarily tamponade effect to slow down the oozing while I'm holding on for somebody to prepare a clip, or if you have a heated probe available, etc. So it's just so that the field is a bit controlled and I can clean up a bit, temporary tamponade. The other area where I think you want to be cautious with your epinephrine is those elderly patients with arrhythmias, and it can you can induce quite a bit of a tachycardia, which is why when you in your large bowel, especially the rectum, and in the esophagus, which have a dual blood supply, that's when you want to really use very small volumes and probably a very low dilution of epinephrine, 1 in 20,000, because the heart rate can really race up then. And if someone's got, especially these, plenty of these individuals come from your ECU. So they already have unstable and angina and have an MI, and the last thing you really want is to increase their heart rate. Nazeer, would you agree with that?
I agree with you totally. In fact, your point is quite valid, because remember, the whole purpose of the epinephrine injection is to create a sense of tamponade so that you can kind of cause a bit of vasoconstriction. And yes, the risk of ischemia does increase in the elderly patients, especially if you use very concentrated forms of epinephrine. So to alleviate that, like Vijay has said, make dilute forms of it. And the second thing is, remember, epinephrine alone is not a therapeutic option individually. It needs to be combined with something else. So yes, use it initially, get your tamponade right, and then get a clip or get a heater probe or whatever else is available to you to be able to control that bleeding from that ulcer. The next point regarding the tachyarrhythmia as well, that happens. I mean, the thing is, sometimes, remember, you're focusing on the point of where the blood is coming out, but remember, feeding that point is a vessel. And often you tend to inject either right next to that point or sometimes into the vessel. And that can cause a serious tachyarrhythmia. And that's when you really panic, because now your anesthetist, if you were an anesthetist, also starts panicking as well. So remember, it's not as an individual therapeutic option, but needs to be used with a combination of something else. So perfect, Vijay, excellent point made on that side. Okay, if I go through there's two more questions or another one. The one says, any role of thalidomide in angiodysplasias? Have you come across any of that, Isneen, already, thalidomide?
Yeah, so basically in angiodysplasias, I think we have increased expression of vascular endothelial growth factors. So what thalidomide does is theoretically it suppresses the VEGF. So they potential, but I'm not. I think the last NEJM article, they actually said there was not much. I mean, no benefit in using thalidomide.
Absolutely. So we had a few patients as well, especially when you do capsule endoscopy and you find that they've got multiple angiodysplasias in the small bowel, and they're coming with recurrent bleeding. One of the things is to consider maybe using thalidomide usually at the dose of about 50 milligrams. But the problem with thalidomide is the tolerance, the toxic profile, and also the compliance thereafter of the patient, and the cost involved as well. So it's not used that often. I think probably as a last resort if you had to use anything. But again, you agree the last NAGM didn't show any benefit in the use of thalidomide for managing major upper GIT bleeds. Okay. Another question that's come up as well, it's around the concept of prokinetics. I know you spoke about the erythromycin as a very good prokinetic pre-endoscopy, 30 to 120 minutes given before at 250 milligrams IVI. Any role for metoclopramide? Have you come
So
up
I think
with that in the reading?
the recent guidelines, they all talk about, they give recommendation on erythromycin than metoclopramide.
Vijay, your side, the practicality, do you use a lot of metoclopramide?
Yes. The short answer is yes. When I say plenty, I think, if you've had someone who's had a obvious upper GI bleed, hematemesis, and you're going to scope them fairly early, you have, it's the only thing that is really available to us. Actually, trying to procure IV erythro, like in mycin, is actually quite hard these days. I really don't know how it's up there and elsewhere in the country, but I've heard that in some places in the world, yes, it is hard to acquire IV erythromycin, so we do use it pre-scope. Before the patient actually comes down to the scope room, we normally say to the intern, well, we actually, Abdul has no interns. We say to the MOs, just give the patient a dose of IV metoclopramide. Just as an add-on from there, Isneen, what is the role of the NG tube
Yeah, good question.
in an upper
NGT.
GI bleed?
So I mean, so if the cause of the bleeding is from like severe esophagitis, so if there's a perforation or a cancer,
No. I'm actually saying this is your run-of-the-mill patient that comes into the hospital, like casualty. It's a young, male, no signs of cirrhosis or portal hypertension, and it looks like an ulcer bleed. And do your surgeons still shove down an NG tube?
no, they don't. They actually call us for a scope.
Okay, so the NG tube has fallen away. You're right?
Yeah.
Nazeer, I think there was no real evidence that it actually helps any. And if anything, it can increase the risk of aspiration, I suppose. And it's uncomfortable, and I don't think it adds anything. I don't know if you would agree with that probably the NG tube for upper GI bleeds is should not be used. I know in the United States, they did recommend inserting an NG tube to see if someone has a GI bleed. I couldn't quite understand that, but hopefully that's been altered now.
Exactly. And in the past, that was, as students before, that's one of the things they would kind of do. You're sitting in the casualty or the resus, and a guy comes with GI bleeding, whether he's not bleeding actively or bleeding actively, but if he tells you I had a bleed or hematemesis, the first thing the reg or the consultant in surgery would tell you, put the NG tube and see if there's blood that's there. But yeah, clearly that's fallen away. And for the reasons that you've mentioned, risk of aspiration, risk of further trauma, risk of perforation, uncomfortable sensation in the patient. It's not therapeutic in any way. If the patient may have an underlying barracks or something that's there as well, you could obviously make that worse. So it shouldn't be, part of the protocol to manage these patients. Okay. One very nice question GGV has put up there, and I'll put it because we're going to be getting for time as well, is HHT, hereditary hemorrhagic telangiectasias. That's a very interesting, cause of GIT bleeding, and sometimes often missed because you may not see anything initially in the upper endoscopy, but this patient comes in with recurrent anemia all the time. And what's your approach to it? The drug VG has mentioned there is got bevacizumab, but Isneen, you're reading for anything else for HHT?
Not sure, but they did talk about like hormonal therapy and other things, even
Okay.
the I'm not 100% sure.
Yeah, no problem. So obviously, Beva is an anti-angiogenic drug, anti-angiogenic drug, but they talk about antifibrinolytics, antibiotics, certain immunosuppressants, etc. But what's a key thing to look at? Sometimes under your patient's tongue is one of the most common place that you would find these HHT lesions. And sometimes you do the endoscopy and they come in, and if you just look under the tongue, you will see a whole lot of lesions that are there that will guide you towards diagnosis. Okay, is there any other questions from anybody else at the moment? Vijay, any closing remarks from your side?
No, no, I don't have any closing remarks except this is a very important that everyone should be quite familiar with. And there's a whole range of endoscopic hardware out there and accessories that can be used. The one I've seen most recently that I'm ain't sure if you've heard about it, Nazeer, is the problem of removing clots where you can't see what's happening, and you go into the stomach, and the stomach is full of blood clots. So I think you recently one of the companies has developed an over-the-scope tube that you can connect through your suction. So you create a large suction, and the blood clots, in essence, get sucked up through the over the scope tube. So you're creating a much bigger space. So the clots actually go around your scope through the over the tube out. So you can connect up a very powerful suction when you're dealing with these big blood clots. But that's quite new. I haven't seen it. The other thing to try and deal with the blood clots that are obscuring your view is sometimes we all scope the patient supine in the left like lateral position. But if you just try elevating the head and shoulder up a wee bit, 45 degrees, that can actually really help sometimes when you're struggling to find the source of the bleed and there's blood clots and blood and fluid all around, to just shift all that away from the stomach into the duodenum. So that can help empty out your stomach, and it's quite safe. So you can just position change the patient with the head up a bit. That may be easier and more inexpensive than trying to locate that, what I'm sure is going to be a very expensive over-the-scope tube to empty out the stomach. But there's quite a few things to speak about in upper GI bleeds. And I think you also spoke about the patient who has a rebleed. Now, if you've applied your endoscopic hemostasis and you were happy and you've got the patient in the ward or in high care on a proton pump infusion and they have a rebleed, my option, and I think what is recommended, is to have a re-attempt at the scope rather than, yes, by all means, you can inform surgery and your interventional, your radiologist, but the general recommendation, insofar as I'm aware, is to take the patient to the scope room and have a reattempt at endoscopic hemostasis. And most of the time, obviously, maybe calling someone to help you. And most of the time, you should be successful. Would you agree with that?
Yes, yes.
Having this, the second attempt at endoscopic hemostasis, I think, is generally recommended, and
So
often it works.
yeah, so like I mentioned, so if
Yeah.
the patient starts bleeding or has dropped hemoglobin of 2, and is having hypotension and tachycardia, then yeah, our approach would be to rescope. And during that rescope, if you are not able to achieve hemostasis, then we would call the intervention radiology or the surgeons. That
Yeah, I
was what.
think, I think agree. I think second look endoscopy is important, especially in this category of patients, because remember, most of our patients are elderly, they've got comorbidities. Question is, will they even tolerate surgery? That's another debate on its own. So whatever we can do endoscopically to try and decrease the risk of rebleeding, I think should be attempted first. But yeah, just keep your friendly surgeon nearby and on speed dial, because these things can really get very scary when you're standing there alone and trying to stop a bleeder. Okay, so that brings us to 1857, and I think we got a bit about a minute left. Maybe one more question from anybody in the audience. Is there anything else or anything else coming through? No? So then we just go
If I can ask you guys quickly, and Nazeer, do you use your heater probes? Heater probes seem to have sort of, if you have one in your unit, it's absolutely fantastic. I mean, we had one years ago, gold probe, and then obviously equipment changed and new suppliers. And somewhere along the line, that heater probe just, I don't know where it vanished to with the Olympus equipment at the time.
Yeah, that's correct. So Olympus has got one. They still manufacture it though. We've got one at Barra, an Olympus heater probe. So it does help. But when you use a heater probe and the thing gets stuck in the ulcer bed and you try to pull a little bit and then it bleeds even more, then your fellow is standing there and you're standing there and you're thinking, now maybe we should have just left this alone. so that is one of the disadvantages.
Yeah, I think the key about using the heater probe is you need to actually press really hard, because you want to coapt the walls of the vessel. So you want to seal the walls of the vessel. So if you're just applying superficial pressure on the surface of it, you're going to cause more harm actually than good. You actually have to physically use a fair amount of pressure with the heater probe. And just one final thing, Isneen, I don't know, maybe I had missed it. The adherent clot. What should you do when you have an upper GI bleed and you have an adherent blood clot over the ulcer?
Yeah, so that's up for actually debate, and most of the guidelines, if you look at the American guidelines, they say try to wash it off with the water, and if you are able to wash it off, then you can intervene. If not, you can leave it alone. And others, they say actively go and remove it with a snare or a
What
forceps,
will
try
you
to
do?
dis. I would remove it.
Even if you have
That's
to
what
use
we can do.
a snare?
Yes, so we
Okay.
use a snare, and then because if patient starts bleeding during the procedure, then at least we can intervene. And so
Yeah,
what we do is we
I think I would agree with that. That is the absolute correct answer. So usually you'll give your saline adrenaline with or without adrenaline. As I said, sometimes I skip the adrenaline. You'd first create some tamponade, and then you should make a concerted effort to remove that blood clot and assess the underlying ulcer base, particularly for a visible blood vessel, which can be quite hard to see on a occasion, because it's those ones that can actually rebleed. Now, that's the correct answer, but in the real world, I'm not quite sure how many people actually are brave enough to go and take that whole thing out and you can risk it. But the correct answer is the one you gave. You should make a concerted effort to remove it.
Okay, everyone, I think that brings us to 7 o'clock on the dot. And so, yeah, that I think brings us to the end of the presentation. So firstly, I'd like to say thanks to the presenters. Isneen, really appreciate the effort you put into this talk, and there was some good discussion and questions after it as well. And so thanks to the ECHO University of Mexico and also ECHO India team for their support website. And we're very thankful to the Gastro Foundation for making this available and for this entire project. And with that, I think, thank you, everybody.
thank you.